Hi guys, welcome to another talk from a TOSA, specifically another talk on obstetrics. I'm John Mark, and today we're going to be talking about the obstetric general anesthetic. A good way to gauge your confidence in this topic is to take a moment to think about your approach to a GA for the Caesarean section. What are your initial thoughts and emotions when the topic of obstetric GAs comes up? I'll tell you some of mine. My first thoughts are that this scenario is usually a hostile one. We know that spinals are the default anesthetic for cesareans, and the decision to perform a general anesthetic is a deviation from the norm. It's often because something has gone wrong, or chances are high that something will go wrong. It can be something as simple as a failed spinal and the stress of keeping theatre waiting, or something as serious as the cord prolapse being rushed into theatre with no warning. The bottom line is this: the fetal or maternal condition has deteriorated, or it's at risk of deteriorating, and this mandates the provision of general anesthesia. To complicate matters, this is on the background of well-established risks of general anesthetics in this group of patients. I feel fortunate in the sense that my career has allowed me to gain a fair amount of experience in this topic. My MMed was on obstetric GAs, and I've done a few academic talks on the subject over the years. I always like to simplify things, and this topic lends itself to this approach. There are several well-established risks related to the obstetric GA, and if we are familiar with the risks, we are able to intervene and institute plans to mitigate these risks. I'm hoping that by the end of this talk, you'll have a better understanding of these risks and why they exist in this group. But most importantly, how you can change your practice to limit your stress and get better outcomes. So let's get into it. South Africa has a high demand for obstetric anesthetic care. This results in doctors with little anesthetic training and experience being required to provide anesthesia for cesarean deliveries and other obstetric emergencies. Many occasional anaesthetists feel comfortable providing spinal anesthesia, but not so much a general anesthetic. While it's reasonable to have a healthy fear of obstetric GAs, it's a critical skill, and one cannot embark on providing anesthetic care in this group of patients without the ability to safely perform a general anesthetic. During this talk, we are going to focus on some of the physiological and anatomical issues specific to the obstetric patient, and how and why they complicate general anesthesia. With that knowledge, we'll then explore various techniques to reduce these risks and make general anesthesia in obstetrics less anxiety-provoking for you and safer for your patient. The real issue to think about is that you have a patient who has a high risk of a difficult airway due to the anatomical changes of pregnancy, with a higher than normal oxygen consumption due to the physiological changes of pregnancy, but with a lower oxygen reserve, again due to the anatomical changes of pregnancy. What this all boils down to is less time to manage a more challenging airway, and often in a time-sensitive clinical scenario at 3 a.m. So what can we do to tackle this? Well, the first step is to be prepared before the emergency arrives. We have a whole talk dedicated to preparing for an obstetric call because we feel this is such an important topic, especially as a junior anaesthetist. If one is familiar with the nuances of the obstetric patient, then one can think about the changes to the GA technique to compensate for them. So why are these patients at increased risk? Firstly, let's talk about the intubation. Why is it technically difficult? Well, the challenge is because of the anatomical changes of pregnancy, and these are an upward displacement of the glottis, airway edema, a higher Mallampati score, increased breast size, making it difficult to insert the laryngoscope, friable tissue, and a higher BMI. So we have a patient who is difficult to intubate due to anatomical reasons, but now we need to also appreciate that we have less time than usual to get the tube in. And this is because of two main reasons. One, the rate of oxygen consumption is higher. Two, the oxygen reserve is lower. And why is this? Well, there are physiological changes that increase oxygen consumption. These are a higher basal metabolic rate in pregnancy, the fetus, which needs to extract oxygen from the mom for its supply, and the stress of labor due to the pain and effort. So that explains the increased consumption. But now we need to appreciate that this is further complicated by a lower reserve. And why is this? Well, simply from a reduced functional residual capacity due to the upward displacement of the diaphragm. There's just less space in the chest. So, to summarize, we have a technically difficult intubation in a patient with a higher than usual oxygen demand, but with a lower than usual oxygen reserve. I hope I'm starting to make you nervous, but wait, that's not all. Don't forget about regurgitation and aspiration risk. And why is this? Well, first, hormonal changes in pregnancy lead to a reduced lower esophageal sphincter tone, and this in turn leads to reflux of acidic gastric contents from the stomach into the esophagus. This is why almost all pregnant patients struggle with heartburn. Second, there's increased intra-abdominal pressure. There's a large mass in there and it takes up space, leading to increased intra-abdominal pressure. Third, there's delayed gastric emptying. This is an issue in labor and is due to the sympathetic response and the effect it has on the GIT. Studies show that non-laboring patients have close to normal gastric emptying times. We'll talk a little bit more about this later when managing the airway. So let's recap again. We have our technically difficult intubation in our patient with higher than usual oxygen demand, with a lower than usual oxygen reserve, and she's at risk of vomiting. It's all starting to sound pretty bleak, so let's add one more concern to factor in. Don't forget about the anesthetic awareness. Caesarean sections are high risk for accidental anesthetic awareness under general anesthetic, particularly during intubation. There's good data from the 2014 NAP5 trial from the UK, which showed obstetric anesthesia, and specifically Caesarean sections under GA, were the most overrepresented of all patient categories. I'll list the risk factors identified in this large trial in a moment, but I want you to picture your typical obstetric patient and think about your standard anesthetic technique for GA Caesars as I list these points. There's 8 of them to think about. It's a rapid sequence induction. There's no opioids at induction. There's low dose induction agents that we use. They were still using thiopental in the UK at the time, but it's likely a similar issue with propofol. The use of muscle relaxant, difficult airways, obesity, short time between induction and surgery, cleaned and draped and surgeon scrubbed, mind the gap, and emergency cases with non-consultant anaesthetists. I certainly tick most of these boxes in my technique. I'm sure you do too. So, another recap. We have a technically difficult intubation. Our patient has a higher than usual oxygen demand. They also have a lower than usual oxygen reserve. They are at risk of vomiting and aspirating, and they might remember all of this. So that explains the increased baseline risk for all obstetric GAs, regardless of the actual indication for the general anesthetic. Now we need to factor in this indication, with the implication that something has gone wrong. Remember, spinals are the default and GAs are the deviation. It could be a failed spinal, no fetal or maternal compromise, but still a stressful situation with pressure to proceed, and you weren't planning a GA. Maternal compromise, for example, an antepartum hemorrhage. Severe fetal compromise with fetal bradycardia on CTG. Severe pregnancy-induced hypertension or eclampsia with contraindication to spinal. It's important to factor in the indication for Caesarean section and the specific requirements of a general anesthetic into your planning. So to conclude the summary of why the general anesthetic in obstetrics carries increased risk, it's critical to understand that it is the combination of all of these issues that make them high risk. But the important thing is how you manage this risk. If you are able to remember each of these issues, you can think about how to mitigate them. And here are some of the things that I do. I follow a stepwise approach to induction and intubation. There is a temptation as one gains experience to miss steps and take shortcuts. This just isn't the patient for this. Let's look at how we should prepare our patient, keeping in mind the risks that we've just looked at and thinking about how each of these interventions limits them. So, firstly, the patient should be starved if it's an elective case. You should follow routine fasting guidelines in elective cases and remember that non-laboring patients have normal gastric emptying times while those in labor have delayed gastric emptying times. This is due to the sympathetic response of labor. 2. Consider a prokinetic, for example, metoclopramide 10 milligrams IVI. The goal is to speed up gastric emptying and thus lower aspiration risk. This takes time and needs to be given at least 30 to 60 minutes pre-op to be effective. It's worth mentioning here that the 10 milligrams of Maxilon is classed as a prokinetic and it works by speeding up gastric emptying. This is why it's used in this scenario and not as an anti-nausea drug. 3. Always give an antacid prophylaxis. For example, sodium citrate 30 ml PO. The goal of this one is to increase gastric pH so that if aspiration occurs, at least the risk of pneumonitis is reduced. It can be given immediately pre-op as it works as soon as it's in, so for this drug, later is better. Number 4, antibiotic prophylaxis. Your institution should have guidelines on what drugs to use. Remember, you're using it as prophylaxis for the skin incision, and thus gram-positive cover is the primary goal. It should ideally be administered 30 to 60 minutes preoperatively. I want to spend a moment here to mention that there are numerous obstetric-related guidelines, and you may read about arguments for giving post-delivery to avoid exposure to the neonate. Try not to get lost in the detail. Antibiotics need to be delivered to the tissue prior to incision to be the most effective, and this takes time. This is obviously not GA specific, and the same would apply before a spinal. Number 5, high flow IV access. Use a minimum of an 18 gauge access and make sure it is free flowing. You can consider 2 18 gauges or even a 16 gauge. I routinely used 2 18 gauge lines when I first started my anesthetic career, and there were 2 reasons for this. The first is how rapidly blood loss can occur during a Caesarean section. It's more than the 90 ml a minute that your green gelco is going to give you if things go wrong, and you simply won't be able to keep up with a single 18 gauge. The second reason is that there is now a line for fluid and a separate line for drugs and the oxytocin infusion. I'm sure you've been in the situation where the baby is out and you've started your oxytocin infusion, but then decide you want to give a fluid bolus. You obviously shouldn't bolus with oxytocin as you'll worsen hypotension, but you also don't want to stop the oxytocin and worry about uterine atony. Having 2 lines solves this problem. Number 6, standard monitoring. This is the minimum of ECG, note the heart rate and rhythm, non-invasive blood pressure, note the starting pressure, and a pulse oximeter, note the baseline sat off oxygen. Taking a moment to actively assess each of these baseline vital signs will quickly alert you to any potential issues. A patient presenting with tachycardia, hypotension, or hypoxemia are all red flags and must prompt further thought. This may well dictate the drugs you choose for induction, as well as the potential for rapid desaturation during the induction period. So let's recap. We ideally have a fasted patient, we've given a prokinetic, we've given antacid and antibiotic prophylaxis, and we've established wide-bore IV access. We've also put on all of our monitors and taken a mental screenshot of our starting point. Now it's worth taking a moment to optimally position our patient for induction, and I'm specifically thinking about how to maximize the effectiveness of my pre-oxygenation and make my first shot at intubation my best shot. So what do? Firstly, I wedge the right hip. This is often forgotten in GAs. This is a tool to improve hemodynamics and reduce pressure on the IVC, thus allowing blood return to the heart, or optimizing our preload. It's important to do this prior to induction, as it's easy to forget, as I said, but mainly because you anticipate a drop in blood pressure as soon as your induction agent goes in. With the wedge in, I then ramp the patient at 20 to 30 degrees head up. I can't emphasize enough how useful this is. There are multiple benefits to this position. It increases your functional residual capacity because it displaces the diaphragm down and thus increases lung volume. There is now more effective pre-oxygenation, meaning a higher oxygen reserve at induction, and the result of this is a prolonged apnea to desaturation time, or simply put, more time to get out of trouble during a difficult intubation. It also allows for easier mask ventilation. This position causes the breast to move down and improves access to the neck and mandible. This makes it easier to perform airway maneuvers to optimize bag mask ventilation. It facilitates better laryngoscopy. As the breasts move down, it makes it easier to insert the laryngoscope. It also improves alignment of the three airway axes, the oral, pharyngeal, and laryngeal axes, improving view at laryngoscopy and increasing the likelihood of a successful intubation. Lastly, on the benefits of ramping, it reduces the risk of regurgitation. This is simply a function of gravity, as the head is now well above the stomach, and passive regurgitation is less likely to occur uphill. I then ask the patient to extend their head. This optimizes the starting position, and the combination of a ramp position with an extended head creates the so-called sniffing the morning air position. It's also a confirmation that the patient can extend their head in this position, something that should have been assessed during the preoperative airway assessment. But occasionally, hairstyles can limit neck extension, and this is something you want to be aware of prior to induction. Another consideration is whether to have the patient cleaned and draped, with the surgeon scrubbed prior to induction. The benefit is a more rapid delivery of the neonate, but at the expense of increased risk of failed intubation due to difficult laryngoscopy as a result of poor patient positioning and the presence of a screen. It also increases the risk of awareness due to inadequate depth of anesthesia during the intubation and skin incision. General anesthesia does result in lower 1-minute APGAR scores when compared to neuroaxial techniques, but by 5 minutes this deficit has resolved. The low 1-minute APGAR is a result of transplacental transfer of both intravenous and inhalational agents, and it's thought that low APGARs due to volatile agents is simpler to manage than low APGARs from IV induction agents. This is because the neonates can be mask ventilated to eliminate volatile agents, but their immature liver and kidneys take time to metabolize IV induction agents. For these reasons, I suggest a hybrid method be adopted, where the surgical team is scrubbed prior to induction, but the cleaning and draping of the patient only proceeds after successful endotracheal intubation is confirmed. Of course, in extremely time-sensitive scenarios like cord prolapse or a severe fetal bradycardia, all of this will be happening simultaneously. Finally, I check that suction is on and working. I then position the Yankauer catheter tucked under the mattress on my right-hand side. This is because the laryngoscope is a left-handed instrument and you will always be suctioning with your right hand under vision should regurgitation occur. Always keep the Yankauer in its packaging after confirming it's on and working, as you don't want to contaminate it and then put it into a patient's mouth. So, moving forward, we now have our pre-medded, monitored, and positioned patient, and it's time to get the show on the road. We'll now spend some time thinking about how to get as much oxygen as possible into the patient before we start. This is simply about creating a buffer of time in case we struggle. We're also going to look at how to keep supplying oxygen during our induction, particularly during the period after apnea has been induced, but before we have placed our endotracheal tube. I want to introduce you to the term apnea to desaturation time. This is the crux of what we're aiming to optimize. The idea is this: how much time do I have to secure the airway and start ventilating from the time the drugs go in? And how do I maximize this time? Simply, there are two concepts to think about. Pre-oxygenation, this obviously happens pre-induction, and apneic oxygenation. This happens post-induction. So what am I practically doing to achieve this? Well, I ensure optimal pre-oxygenation with a tight-fitting mask on 100% FiO2 at 10 liters a minute, and I aim for an end-tidal oxygen of 90%. The goal is maximizing pre-oxygenation and thus prolonging the apnea to desaturation time because there is a high oxygen reserve. The next thing I want to do is to try and keep a steady supply of oxygen during this apneic period. That is, after induction, but prior to intubation. And this can be achieved with a few techniques. Number one, bulk flow of oxygen during apnea. If you supply oxygen to the pharynx at a high enough flow rate and the airway is patent, then oxygen will move down its concentration gradient from the pharynx and into the lungs. This requires keeping your fresh gas flows high, at least 10 liters a minute, and making sure you have a tight-fitting mask and a patent airway. You can use a two-handed technique to keep the head extended and ensure a good jaw thrust, and make sure that the face is lifted and tightly fitted into the mask. Number two, nasal prongs at a flow of at least 5 liters a minute. This adds another 5 liters per minute of oxygen being delivered, and again, it relies on the bulk flow principle. It requires a patent airway from the nose to the lungs. The method here is to place the nasal prongs prior to starting induction. I connect to the auxiliary oxygen flow meter and start at 2 liters a minute for comfort. Post-induction, I increase the flow to 5 liters a minute and I hold the mask as described above. I now have a combination of 5 liters a minute of oxygen coming from the nasal cannula and 10 liters a minute coming through the mask. This gives me a total of 15 liters a minute of oxygen constantly being supplied to the patient's upper airway. One can also consider the use of nasopharyngeal cannulas. These are designed to deliver oxygen directly to the pharynx and are useful if there is no patent airway. The cannulas bypass the upper airway and deliver oxygen close to the cords. Number 4, mask ventilation at low pressure, so-called gentilation. I'll describe this technique more in a moment. And finally, high-flow nasal oxygen therapy. I won't go into detail as this technique has not yet been studied in the obstetric patient, but watch this space. So with all of these interventions in place, I feel that I both maximize my oxygen reserve and maintain a steady oxygen supply, and thus give myself the maximum time to successfully manage the airway, particularly if I face any difficulty. So now, let's talk a little bit about the actual process for induction, and the key terms here is a modified rapid sequence induction. I'm sure you're all familiar with the standard rapid sequence induction, but it's worth thinking about why we do it and what exactly the standard rapid sequence entails, so that we can then talk about the modifications that we're going to make. Just remember, the whole point of doing a rapid sequence induction is to limit the risk of regurgitation and aspiration. It's reserved for the patient with a full stomach or an increased risk of aspiration. So the standard rapid sequence induction includes some of the following: adequate pre-oxygenation, pre-calculated doses of induction agents, a rapid-acting muscle relaxant, the use of cricoid pressure, and no mask ventilation prior to intubation. So, how are we modifying our rapid sequence induction? Well, firstly, we will adequately pre-oxygenate and plan for apneic oxygenation as discussed above. The use of cricoid pressure is still widely advocated in the rapid sequence induction by the Difficult Airway Society guidelines, but there is now the caveat to have a low threshold to abandon if you feel it is hindering you. The benefits of cricoid pressure is that it theoretically lowers the risk of regurgitation by compressing the cricoid cartilage onto the esophagus and thus lowering the risk of gastric contents entering the airway. There is also less insufflation of the stomach if mask ventilation is used. The risks are a worse view at laryngoscopy, as the anatomy can be distorted by the cricoid pressure, and it can also be more difficult to insert an endotracheal tube or your supraglottic airway. Suggested drugs for the modified rapid sequence induction are propofol at 2 to 2.5 milligrams per kilogram and succinylcholine at 1.5 milligrams per kilogram. Thiopentone is the historical drug of choice, but it is no longer available in South Africa. Rocuronium at 1 to 1.2 milligrams per kilogram is an acceptable choice, but only if Sugamidex is available. Mask ventilation is not part of the classic rapid sequence induction due to concerns of insufflation of the stomach and increased risk of regurgitation. However, mask ventilation is now widely considered an option in rapid sequence induction, specifically with the term gentilation. What this means is that mask ventilation at a pressure of less than 20 centimeters of water with cricoid pressure applied. The idea is that you are facilitating apneic oxygenation while still limiting the risk of gastric insufflation by using low pressures and applying cricoid pressure to limit the risk of gastric insufflation. A further benefit of employing gentilation during induction is that you can introduce volatile into the circuit earlier. Remember, general anesthesia for Caesarean section carries a higher risk of awareness, particularly during induction and intubation. The reasons for this are that we tend to use lower doses of induction agent, we don't use co-induction agents, and we often struggle with intubation. And what this means is it takes a long time. By the time we've established a secure airway, the effect of our induction agent has started to wear off, and there is thus a risk of awareness. This graphic shows how the effect of the induction agent is decreasing prior to the volatile agent reaching an adequate MAC. This is the so-called gap, and it is increased when the airway is challenging and takes time to manage. A final benefit of using mask ventilation during induction is that you've answered the question of whether it's possible to mask ventilate or not. If the patient is easy to mask ventilate, then the pressure is off. Even if laryngoscopy or intubation is difficult, you already know that mask ventilation is a viable option as a bailout. However, if mask ventilation is not possible, then you can move through the difficult airway algorithm more quickly should you need to, as you already know that mask ventilation is not an option. So, moving on. Once intubation is successful, always confirm placement and depth of the tube. It's easy for tubes to migrate in stressful situations, and we don't want an accidental extubation or an endobronchial intubation with the risk of bronchospasm and one-lung ventilation. Make a mental note of the depth by calling it out to your anesthetic assessment at the moment of intubation. Then make sure you confirm this depth as you secure the tube. You should then immediately confirm correct placement by taking a pause and watching for 7 peaks on the capnograph. This is also a good moment to collect your thoughts and reassess the patient's condition as you move from the induction phase to the maintenance phase. Before moving on though, I want to mention the use of video laryngoscopy in obstetrics. Current literature suggests that video laryngoscopy should be standard practice for the obstetric general anesthetic. However, it may not always be available where you work. As video laryngoscopy is not always available, you must be comfortable with traditional laryngoscopy first. You should then learn to be comfortable using a video laryngoscope. This will give you the confidence to use either. Thereafter, my suggestion is using video laryngoscopy as standard if available in your institution. Remember that certain video laryngoscopes are designed with specific introducers, and you must be comfortable using them. You should also use introducers in general if you're comfortable with that. Always remember to lubricate them well. There's nothing worse than a successful intubation and then battling with a stuck introducer as you hear the patient start to desaturate. Finally, a quick word on supraglottic airway devices in the obstetric patient. There is literature suggesting that supraglottic airways are safe for routine use as the standard airway device in routine elective Caesars. I don't think we're at that point where we can advocate this as standard practice, But with that said, it should give you confidence to use them as a rescue airway if a difficult intubation is encountered, and there's no need to panic if you have bailed out to a supraglottic airway device and it's working well. You now have time to plan what to do next. So now we've covered patient preparation and positioning, as well as the modified rapid sequence induction for our routine obstetric general anesthetic. Let's now spend a moment talking about the difficult obstetric airway. We have an entire talk dedicated to airway management and difficult airway scenarios, but it's worth knowing that the Difficult Airway Society has specific guidelines for the obstetric airway. So what are the differences from the standard difficult airway guideline? Well, the standard algorithm is in keeping with the approach that I have described above for the first attempt, so that's easy enough. If unsuccessful at the first attempt, change something. We will talk a little bit more about this in a moment. If the second attempt is also unsuccessful, then a third attempt should only be attempted by a more experienced person if they're available. Otherwise, you move to mask ventilation, ideally with a two-person technique, and then onto your rescue airway, which is a supraglottic airway device. If successful with the supraglottic airway, then a decision must be made on whether to continue or abandon the case. However, if unsuccessful with mask ventilation or a supraglottic airway, then front of neck access is the only option remaining. Have a look at our difficult airway talk to learn more about this technique. So, to summarize that, attempt 1 is based on everything in this talk up to this point. If unsuccessful, change something and try again. If successful, great. If not, then you only get a chance at a third laryngoscopy if someone with more experience arrives. The big difference is that you only get 2 chances, and then you need to move on to a rescue airway, either mask ventilation or a supraglottic airway device. If these both fail, then a surgical airway is the final option. The fundamental difference is 1 less attempted laryngoscopy and intubation, and the reason is because obstetric patients desaturate faster, so one needs to move through this process faster than usual. So I mentioned earlier that you change something if you are unsuccessful on your first attempt. So what can we change? Well, we can optimize position, although the whole point I've been trying to get through earlier in this talk is that optimizing position as standard is always your best bet in the obstetric patient. So, if they are not ramped, you can ramp them, and if they're not in the sniffing position, you can optimize position now. You can also use a different laryngoscope. There are various options, including a different size blade, a short handle, or a McCoy blade. Take time with your second laryngoscopy, inserting the laryngoscope on the right side of the mouth, careful to sweep the tongue to the left, and aim to identify airway anatomy as you go, trying to identify the epiglottis. You can release cricoid pressure. As mentioned above, you should have a very low threshold to release cricoid pressure if you feel that it is obstructing your view. You can try burp, that's B-U-R-P, or backwards, upwards, rightwards pressure. This maneuver allows your assistant to help bring the larynx into view. It requires good communication and often you guiding them with your right hand until a good view is obtained, and then asking them to maintain it. You could also use a bougie, and you can call for a video laryngoscope if you haven't used one and it is available. I hope you're taking away that many of the change somethings are the same things that I'm suggesting as standard practice for the obstetric GA. The whole point of this is recognizing that these airways are well known to be difficult, and the extra attention to detail applied as standard to every case is the way you stay out of trouble. It's about the discipline to take an extra few moments to optimize position and oxygenation as your standard, every time. Okay, so the focus of this talk has been on the approach to induction and airway management in the obstetric patient. This is where the highest risk lies. However, there are also some amendments to the standard GA technique post-induction during the maintenance phase. So let's talk about this for a little bit. The main issues to consider for maintenance anesthesia are the use of nitrous oxide, the oxygen concentration, and the minimum alveolar concentration, or MAC targets. Nitrous oxide is still commonly used in obstetrics, with benefits being rapid uptake, analgesia, and less tocolytic effect on the uterus than other volatiles. Historically, oxygen concentrations of 50% have been used, but multiple studies have shown no change in fetal outcome with lower concentrations. I routinely target 30 to 35% if my oxygen saturation remains above 94%. In the presence of fetal compromise, I still target 50% until the baby is delivered, and then I target the 30 to 35% FiO2. The benefit of targeting this lower oxygen concentration allows us to make up the difference with a higher nitrous oxide concentration, up to 65 to 70%, and in turn, a lower halogenated volatile without increasing the risk of awareness. Adequate target MAC is still debated in pregnancy, as it is thought that the MAC requirements in the pregnant patient are reduced by up to 40%. The risks of increasing the MAC are neonatal sedation and potentially increased blood loss due to uterine atony. An end-tidal MAC of 0.5 for the halogenated volatile, combined with the high nitrous oxide concentration, as mentioned above, is my suggestion. Prolonged exposure of the neonate to volatile anesthetic agent may result in sedation and low 1-minute APGARs, but this is easily managed by assisted ventilation to expel the volatile agent via the lungs of the neonate. As mentioned earlier, a prolonged IV induction to inhalational volatile interval is a risk for awareness, and it most commonly occurs just after induction and during intubation. For this reason, it's now being advocated to use an overpressure technique to rapidly achieve adequate end-tidal concentration of volatile agents. This involves initial high volatile concentrations with high fresh gas flows. It is implied that vigilance is required to adjust these settings when the target MAC is achieved, and you must be extremely cautious if you adopt this approach. With hypnosis sorted out, we now need to think about analgesia. The high dose of nitrous oxide will provide some analgesia, but it is not adequate as a sole agent. Opioid timing has long been a highly contentious point in obstetric anesthesia. Many fear giving opioids pre-delivery due to the respiratory depressant effect on the neonate. Remember, opioids cross the placenta. My suggestion is to avoid giving opioid until after delivery, and then to use a rapid-acting agents such as fentanyl or sufentanil, as well as a longer-acting drug such as morphine. If there is an indication to give an opioid prior to delivery, for example, to blunt intubation response, remember to inform the midwife or pediatrician taking care of the neonate. IV paracetamol and non-steroidal anti-inflammatories are excellent adjuncts for pain management and should also be given post-delivery. A word of caution with anti-inflammatories: if bleeding risk is assessed as being especially high, they can cause more bleeding. Local anesthetic to the surgical wound by the surgeons at the end of surgery is also a very effective option. Further doses of muscle relaxants may be required. Just remember, if SUX was used for intubation, you want to see reversal prior to giving a non-depolarizing agent. Scoline apnea is rare, but it becomes complicated to diagnose if another muscle relaxant has also been used. Remember that the dose required is not the intubation dose. You are likely only going to require 20 to 30 minutes of paralysis, so start with half an intubation dose of rocuronium. It will take a couple of minutes to work, but you don't want to overdose and not be able to extubate when the surgery is complete. Also remember that magnesium sulfate causes prolonged duration of action of non-depolarizing muscle relaxants, and it is commonly given to obstetric patients, particularly those with hypertensive disorders of pregnancy. Finally, always use a nerve stimulator to confirm that the patient is reversible prior to administering reversal agents. Fluid management must be tailored to each case. You will not need to co-load the patient as you do for a spinal. However, patients may have been NPO for many hours and thus dehydrated, or the indication for Caesarean section or GA may be bleeding, and these patients may require fluid boluses or blood products. On the other hand, you must be cautious with fluid administration to patients with hypertensive disorders of pregnancy. Bleeding is a risk in any caesarean section, but it is especially a high risk for those requiring a general anesthetic, as many of the conditions that necessitate a general anesthetic are also associated with increased risk of bleeding. Examples are antepartum hemorrhage, coagulopathy, placental abnormalities, etc. Remember to use a stepwise approach to uterotonics and give 1 gram of tranexamic acid over 10 minutes post-delivery. Also remember that uterine atony can be worsened by volatiles. Finally, a quick word on ventilation. These cases can be high stress, so keep things simple. Ideally, set your vent prior to induction to avoid having to think about it later. I suggest using a simple volume-controlled mode with a tidal volume of 6 mL per kg, a respiratory rate of 14, and an IE ratio of 1:2 with a PEEP of 10. We want to keep those lungs expanded. Your compliance will change as the abdomen is opened and the baby is delivered, and a volume control mode is the best way to stay on target. When things have settled, you can always switch to a pressure-controlled mode if you're comfortable with that mode of ventilation. The final aspect to focus on is emergence. This is a part of anesthesia that we rarely focus on, but it's worth giving some thought. Post-Caesarean section patients often wake up poorly. They tend to be agitated and are often in pain. They are prone to de-recruit, and I advise weaning them onto a support mode of ventilation like CPAP or pressure support until extubated. Don't forget that all rapid sequence inductions are an indication for awake extubations. The aspiration risk still exists. Consider the use of a bite block between the molars and always ensure adequate muscle relaxant reversal prior to extubation. Finally, if the intubation was difficult, take extra care at extubation. It's not an airway that you want to tackle twice. These are patients to be patient with. Take your time and only extubate when you are certain that the patient is capable of maintaining their own airway, so you don't have to. Practically applicable advice to help you provide high quality care to your patients. And I'll now summarize the various issues that we've discussed and present an anesthetic technique based on this. While clinical scenarios vary, this summary should serve as a broad guide on the various amendments that one can make to their technique. The various amendments one can make to their technique when administering an obstetric GA. This is the technique I use for all my GA Caesars. Patient position. I make sure I remember to put a wedge under the right hip before I start. I ramp the patient at 20 to 30 degrees head up. I think it's unnecessary to clean and drape prior to induction if there's no indication for immediate delivery. I pre-oxygenate on 100% FiO2 for at least 2 minutes, aiming for an end tidal oxygen of 90%. Often 80% is the maximum achievable. High flow oxygen at 10 liters a minute with a tight fitting mask is maintained after induction, and I consider the use of a high flow nasal cannula in addition to this at 5 liters a minute. I will also use nasopharyngeal cannula if they're available and if I think I'll have difficulty maintaining an open airway. I'm also using high flow nasal oxygen therapy if available in high risk patients. And I use nasopharyngeal cannula if available, and I think it will be difficult to maintain the airway. I use cricoid pressure. The guideline is to use 10 newtons pre-induction, increased to 30 newtons post-induction. No one knows what this really means, but the point is always think about patient comfort and only increase pressure as the patient is induced. I maintain it until successful endotracheal intubation has been confirmed, but I have a low threshold to abandon it if I'm struggling, and I think that the cricoid pressure is contributing to the difficulty. For an induction agent and muscle relaxant, I routinely use propofol at 2 to 2.5 milligrams per kilogram and succinylcholine at 1.5 milligrams per kilogram. I will also use rocuronium at 1 to 1.2 milligrams per kilogram where I have sugammadex available. Of course, the dose of propofol is variable, and I certainly amend my induction agent choice if the patient is hemodynamically unstable. Face mask ventilation. I use gentilation or gentle bag mask ventilation. Remember, it's 20 centimeters of water or less, and the patient is gently mask ventilated post-induction but prior to intubation. I then overpressure the halogenated volatile, remembering that I'm trying to mind the gap and reduce the risk of awareness. Videolaryngoscopy is my standard choice. For maintenance of anesthesia, I use an inspired oxygen concentration of 33%, with nitrous oxide making up the rest. My halogenated volatile, I keep at a MAC of 0.5. Blood pressure control is as per spinals. It's often less of an issue in general anesthetic, but it is an issue to consider. You must avoid hypotension. Keep the systolic blood pressure or MAP target within 10 to 15% of baseline, using phenyl or ephedrine or fluid boluses as clinically indicated. Post-delivery, oxytocin as per usual spinal dose for Caesarean sections. I spent some time on this in the Caesarean talk, but just as a reminder, I give 2.5 units IVI stat post-delivery, watching for hypotension. I then put the remaining 7.5 units in 1,000 ml of crystalloid, and I infuse this while in the operating theatre. When I'm in the recovery unit, I put a fresh bag with 20 units in 1,000 ml as the maintenance dose, and I run this at 125 ml an hour. This avoids over-administration of oxytocin during the Caesarean section or in PACU, and ensures the 8-hour infusion post-operatively. Remember, the whole point is to reduce the risk of PPH, and this often happens after the patient has left the post-anesthetic care unit. It should ideally be run via an infusion pump, but a dial flow rate control is acceptable. Carbetocin is an alternative to oxytocin, should you have it available. The dose is 100 micrograms. There's 1 ml in an amp, which contains this 100 micrograms, and it should be given by slow IV injection over 1 minute post-delivery. It's easiest to dilute it to 10 ml to ensure slow administration, as rapid administration causes nausea, a metallic taste in the mouth, and flushing. For analgesia, my nitrous oxide provides analgesia pre-delivery and post-delivery. I then employ a multimodal analgesia strategy, which includes IV paracetamol, non-steroidal anti-inflammatories, opioids, and local anesthetics. I give these analgesics post-delivery of the fetus. Ketamine is an option for analgesia prior to delivery, but warn pediatrician if used. I use both rapid onset opioids, for example fentanyl, and long-acting opioids, for example morphine. Have a look at our analgesia talk on how to titrate these opioids. I often deepen the level of anesthesia post-delivery. And for emergence, I extubate awake, remembering that all the risks present at induction are still present at extubation. To conclude, I want to remind you about the ESMO-E guidelines. This is a highly valuable resource for junior anaesthetists. It focuses on pre-operative assessment, theatre preparation, spinal and GA techniques, essential drugs, and how to prepare them. My suggestion is to have it printed and displayed in all obstetric theatres. The topic of obstetric anesthesia is broad and critically important to the learning anaesthetist. We have several talks on various aspects of this topic, and I suggest listening to all of them. Today, we are focused on safe general anesthesia in the obstetric patient. We have particularly focused on airway management and the anatomical and physiological changes of pregnancy that increase the risk of this group. The key message is that these patients are more difficult to intubate due to these changes, and they are simultaneously more likely to desaturate than non-pregnant patients. This unfortunate combination is the reason why we must be overly prepared and amend our technique to guard against it. In addition, we must keep in mind the increased risk of regurgitation and aspiration in the laboring patient, the increased risk of awareness, and finally, the second patient, the baby, who is relying on us to keep their oxygen and blood supply adequate. We really hope that you find this approach useful and that it reduces the stress that always comes with a GA Caesar. Thanks so much for listening.